Distinguished colleagues, we are working further because of the timing. Our session is devoted to epidemiology of new COVID-19 in the EECA countries, and I think I will speak as the first one. We are inviting the colleagues. We will start to speak about the Russian case of coronavirus infection. So let me start from the initial positions. 2019 gave us just a new task, and I mean 2020. COVID-19 is a new task for us, and please put my presentation on. Now I will speak about the Russian Federation, and further on I will speak about Belarus Republic. And we try to analyze this topic also now. And the knowledge has no borders, and in-depth study is just opening new lines of study for us. And I will just try to show you a certain epidemiological features and the approaches that are nowadays used in the Russian Federation related to coronavirus infection. Now I will handle my presentation. And so let us commence. Coronaviridi are really known to the humankind from the very beginning. And we know that alpha coronaviridi are resulting in 10 or 20% of diarrheas in the childhood, mainly. And we understand that everybody is now looking for beta coronaviridi, and we know that this is the third occurrence of coronaviridi in the 21st century, and nobody was waiting for such disastrous event related to this particular infection. As of now, I will now speak about the numbers, but you see they are really significant. In the world, we are now over 140 millions of infected persons. Lethality is more than 3 millions, and day-by-day accumulative effect of the virus is providing for median amount of new cases at the level of 600,000 cases, and 15,000 are dying. So we day by day are changing the information. The maximum growth is in Sweden, in France, in Brazil, in Czech Republic, in Italy, in the USA, in Russia, in Great Britain, and in Italy also. And I already specified that this is the case for Russian Federation also, and this is a acute case. The scale of the disaster is identical on the planet Earth. In all countries, we see pretty much the same epidemiological trend, which is represented here on this slide. And this particular slide that you are seeing right now is comparing the so-called spring of 2020 and the autumn rise that we are now living in until now. And you see that this disaster is multiple times higher than we've seen it before. And the dynamic of the epidemiological process is related to this curve on this slide. There are different scenarios, but in a matter of fact, when we speak about the second wave or third wave, in terms of Russian Federation, we are not speaking about it, because the classical definition of a wave is zero peak and zero. Russia did not cross the zero line in any situation. Therefore, we are speaking about ever-going, ongoing epidemiological process, spring rise, autumn rise, within the first and the second year. We see all the age categories, and the mortality is growing, and coronavirus infection is also included into this epidemiological process, and there is only one exclusion in children. And when we speak about Russian Federation, as of now, we've surpassed the barrier of 4,700,000 registered cases. more than 106,000 lethal cases. And as of now, when we assess the situation for Russia, we're going through stabilization of peak processes with the tendency of a decrease. According to the overall registered new cases, we are on the 5th place. Overall morbidity per 100,000, we are on 69th place. Absolute lethal cases, 7th place. Lethality, 60th place, and mortality for 100,000 people in population, we are on the 60th place. When we analyze all the age groups, we can see that all the age groups in Russia are subject to COVID-19. For children, we are estimating 11% of all new cases in 2020. The most vulnerable category were the children until 1 year and adolescents, who resulted in the maximum registration in children. And in adults, we see the maximum vulnerable category from 20 to 65 years old. And again, please put your attention to this, that within the group from 20 to 40 years, we have a prevailing share of males, and in the group of patients older than 45 years, there are more female. So the severity of cases is also represented by this trend. You may see it on the slide. We see that with the aging, we have more severe cases. The red part is the acute cases on the diagram, and it is vividly shown starting from the age of 20. Again, I want to remind that the lethal cases are in all age group, but 65 plus age is the special category. We understand that when we speak about epidemiological process, we need to speak about laboratory diagnostics. No microbe, no diagnosis. I want to remind you that laboratory diagnostics in Russia is affected within the sanitary norms and regulations on the previous slide. And as of now, we've made more than 125 million tests. Russia is on the plateau, 300,000 tests daily, and as of now, more than 1,000 laboratories in Russia, state and private laboratories, commercial laboratories, are testing for RNA COVID. On the 16th of April, Russia is among the 5 main countries in absolute numbers of the tests in the world. Why do we need testing and screening activities for SARS-CoV-2? At first, asymptomatic forms of infection. And you know, I'm 40 years in infectious diseases, and at COVID-19 we could describe by the means of the test the form of virus infection process that is playing a significant role in the infection. So early isolation of the sources of infection, we need to decrease the intensivity of circulation of virus, decrease the epidemiological risks in certain categories, monitoring of changes and evolution of the virus, and monitoring of the epidemiologically significant mutations. And as of now, there is a new situation for Russia. We have registered 304 test systems for diagnostics of COVID-19. The Central Institute of Epidemiology that I represent is one of the developers of the key test systems. Let us start from the fact that in March we registered universal test system that provides for COVID-19, MERS, and SARS-CoV-1. And this is the only one test system out of 300 test systems that provides for one-moment etiology reactions. We are the only one developers of quantitative or definition of virus. There are no other products in the world. Why do we need to speak about quantity of the virus here? It's very important for no symptom or asymptomatic low symptom form also that are sources for the infection. We need to test persons that are crossing the borders of Russian Federation at different stages of infectious process or at the end of incubation period. The quantitative system is very important for forecasting, for screening, or in non-infectious hospitals. This is also an additional test at the primary testing, and it can be used to assess the environment. By the way, in 2020, the Central Institute of Epidemiology issued 75 million kits for definition, and the share on the market of test system is 83% for our institute. Yes, we've had some problems with reagents, with the plastic parts of the test kits because of the lockdown, but the decree of the government of Russian Federation is fully executed, and on the 1st of April we've reported the sufficient quantity of test systems that were designed, and like Revert and Reverta L and RiboPrep reference tests are also issued and produced by our institute. By the way, what was the way of work of the Central Institute of Epidemiology? In 2020, we've made 2 million tests by PCR, more than 250,000 research by EFA, more than 400 full genomic RNA sequencing of the coronavirus, and we could provide for a significant support of the vigilance and control over COVID in Russia and abroad. And there was also one important thing. We needed to develop not only a test system, but to integrate the test system into the information sources. As of now, we see that we've created the system that is patented and that provides for obtaining of the results of analysis and during 24 hours to place the data on all platforms in Gosuslugi State Services platform or EMEA system. And here, as of now, there are 16 regions working within this process, and after we get the positive or negative information on the test, it is integrated into informational platforms that are represented here on this particular slide. And I want to remind you that this integration to create this informational database is made within the decree of the government of Russian Federation. What are the most vulnerable categories with the most often positive tests of COVID? Of course, these are pneumonia cases, acute respiratory diseases. And by the way, it was very important fact for us. We were seeing just the different contacts with COVID-19 here. As of now, the main goal of diagnostics is to decrease the time for plastic analysis, flexible analysis. And here, under this situation, our institute created a test system that is of now under licensing. This is LMP kit that provides for a significant shortage of analysis until 1 hour, so we can shorten the time. And also very important epidemiological research is related to the mutations. As of now, we see that N501Y mutation is the main part of the British mutation, South African, Brazil mutation, and other mutations that are significant. And in this situation, we may say that the British stem, and this is the so-called British because for the first time it was eluded at the end of August 2020, it is now seen in 101 countries around the world, and this stem is having increased contagiosity and the mortality by 64%. South African stem, as of now, it is evident in 64 countries, and Brazil and Japanese in 38 countries. Monitoring of the changes of the properties of the coronavirus is one of the most important scopes of our work. And thanks to the Russian Federal Service for Surveillance on Consumer Rights, Protection and Human Well-being, our institute is running full genomic sequencing and bioinformation analysis that provides for forecast of epidemiological situation and analyze epidemiological landscape. I don't want to speak about why do we need to understand the study the mutation, because we are we are protected from the body, from the virus by antibodies, and virus wants to live on and wants to cross the barriers. And the first barrier, the zoonotic barrier, is already closed, and this is the pathogenic process. This process will go on, and we want to put it on hold, of course. The very often mutation are seen in persons with chronic infections, with compromised immunity. From time to time, there is a classic zoonotic transfer from the mammals in persons with a therapeutic treatment, like a treatment with monoclonal antibodies or serum treatment. And by the way, here I need to state that it's a very important moment here that after the introduction of virus in new population, we have single variants, but then the variants may become contagious and dominate. And as of now, all the research is working with two locus, N501 and E484. In the whole world, we are actively tracing this mutation, and we understand here that sequencing helps us to really monitor and assess the situation. And 15 Institute of the Federal Service for Surveillance on Consumer Rights and Human Well-being is running full genomic or fragment sequencing. All these institutes are doing this work, and again I want to say that we are assessing the landscape of distribution of coronavirus. And centrally, Institute of Epidemiology, according to the ruling of the government of Russian Federation, is the main center that accumulates all information. As of now, we have web platform to load the analysis of data, providing for the results of sequencing. And I want to remind you that before we were placing the results in the World Gene Bank. This was a good world practice. And as of now, we have a Russian platform that provides for tracing of serum changes in circulation of coronavirus. And one of the information on the 15th April is registered in Russian Federation. So in Russia, we've registered British cases 192, South African clades 21, 0 of Brazil type coronavirus. But there is also a very interesting position. In 66 patients, we've seen the mutations, important mutations, because we can be reminded that we've got the Western European and Siberian mutation that was seen in St. Petersburg, and their epidemiological role is now under assessment. So the countries of import of coronavirus, there is a firm control, and from yesterday, I want to remind you that we have double PCR tests in interval 5 days, multiple or bound, combined. This is combined to the situation that is on this slide, and there are the countries from which we've got the imported mutant viruses. And here's the distribution on the territory of Russian Federation. It is also on the website of Rospotrebnadzor, Federal Service for Surveillance on Consumer Rights Protection and Human Well-being, of the British, of the Southern African stamps. And here you see the distribution of the stamps like a mosaic, like a puzzle here. But there are some rules of distribution of mutant coronavirus that we are naming the so-called British ones. A very important moment here is a phylogenetic analysis of building of a gene tree and the tracing of the parts of the tree who are maximum distributed. As of now, on the basis of our institute, we've created the National Registry for Gene Sequencing. And here it is the name of it. It is created from the 1st January 2021, and all institutes at the Rospotrebnadzor, Federal Service for Surveillance on Consumer Rights, they are providing for phylogenetic analysis, and in yellow you see the British clade of the virus. Therefore, it's very important to provide operative analysis in morbidity for COVID-19, and the Central Institute, Research Institute of Epidemiology is the main institute here. It's providing for operative reaction. We are preparing day-by-day reports for Rospotrebnadzor. We are analyzing epidemiological situation in Russia for the longer and closer perimeter in the countries of the world, and we are also making short-term forecast for epidemiological situation in Russia. Speaking about Moscow, we may understand that as of now for Moscow we see the phase of stabilization with this tendency of decreasing of epidemiological process. Very important is the circulation of virus. We are not decreasing the quantity of tests, but positive probes, there are less and less of them, fortunately, but still the international criteria of epidemiological state is the index. If it is more than 1, we need to be aware of this epidemiological situation. And by the way, yesterday the city manager of Moscow stated that we wanted, of course, to have the index, the RT index, less than 1, but the trend is unfortunately positive. Just a couple of words about the key element of prevention, because we understand that epidemiology and prevention are bound to each other by one chain. I will not speak about non-specific prevention that is, of course, clearly outlined, and it it is a rule, because in the spring there was also criteria for Rospotrebnadzor developed for lifting of the lockdown measures, and we understand that barrier method like masks, gloves, social distancing, in the spring, when there was no vaccine, they could help us with this problem. But let us speak about vaccination. So in the world, there are different vaccines. In Russia, there are 3 of them. They are for Spago type, to not provide for adhesion of virus and not to start the vaccine. The infection process, there are 3 vaccines registered: vector vaccine, peptide vaccine, and the classical vaccine. They are registered, like Covivac from Chumakov Center. And the scope of vaccination, as yesterday, is here on the slide. We see we've got inoculation of 16 million doses. And speaking about the scope, and Russian is in the 3rd dozen of the countries. And facing this situation, Russia, as a country and institute, see the following epidemiological task. We need to understand the longevity of post-vaccination immunity and preservance of this immunity. Again, with this, we need to assess also in the decreated groups the times for revaccination if necessary, and we also need to follow up the persons after disease and understand when, after the case of the coronavirus, we need to introduce vaccination. And the key moment here is also the development of special test systems. I want to remind you that for the diagnostics of coronavirus, we are using test system for N protein or nucleotides or domain binding receptors. Test systems that are assessing the post-vaccination immunity have a more finer immunology features. Therefore, there is a mismatch. And after vaccination, if you want to provide, you get the tests, the amount of antibodies, you get the post-infectious bodies. And this is a bit of mixing. Of course, we are engaged in international activities. Let me not speak about this, but according to the decree of the government, we've passed 25,000 cases for 2.5 million of tests for more than 40 countries of the world, and we are working under the aegis of the Russian Federal Service for Surveillance on Consumer Rights Protection and Human Well-being for prevention and scientific and methodological support and diagnostics, of course. As of now, we're working with a line of international institutes like Robert Koch Institute. With Robert Koch Institute, we have a long-time scientific basis and platform to provide for research not only related to COVID-19. And this institute, Robert Koch RKI, is working under the aegis of WHO and other international events and agencies. And this is our inlay for 2020 in popularization and raising awareness on COVID. This is the publishing rate of information that we've got by analyzing the masses of epidemiological cases. And at the end of 2020, at the beginning of 21, we are working. Thank you very much for your kind attention. And let us hope, really, that... So we are at the end. We hope that we are at the end and we will finalize the case with COVID. Thank you. Distinguished colleagues, let us be co-chairs today. While I am preparing my next presentation, I will let the floor to Dashkevich Alla Mikhailovna, head of the Department of Epidemiology at the Republican Center of Hygiene, Epidemiology and Public Health in Belarus Republic, COVID-19 in Belarus Republic, the emerging of epidemic, and measures to minimize the risks of disease distribution.
Good afternoon, dear colleagues. Let me thank you for giving me the opportunity to take part in this conference. In the Republic of Belarus, we organized our work to counteract COVID-19 in the beginning of 2020. Proceeding from the study of the epidemiological situation as well as the WHO recommendations, added by data on the new virus, we created an interagency working group led by the Deputy Prime Minister of the Republic of Belarus, and we developed and implemented the comprehensive plan of measures how to prevent the bringing of the virus to the territory of our country, and it provided for the cooperation between different governmental bodies. We conducted some activities on ensure the sanitary control for those who were crossing the border of our country. And another set of measures was implemented to train, when it comes to theory and practice, our professionals, to make our medical organizations ready for identifying and treating COVID-19 patients. And we also provided our framework of laboratories. We expanded our network of labs that were conducting tests. The first infection case in our country was on the 27th of February, proceeding from the epidemiological data, and then we were proceeding from the molecular data, and we concluded that it was brought from Iran. And in March, we registered the infected cases in 4 districts of the Republic of Belarus. They came from Italy and Portugal. And in the beginning of April, the 2 remaining territories of the Republic of Belarus also were registered with some infected cases. So those cases weren't brought from abroad, but they were brought to these regions from other regions of Belarus. And during the 10th through 13th weeks of 2020, we registered infected cases mostly among those people who came from abroad, from Europe mainly, and those who were in contact with those who came home. After that, we identified that the virus started to spread across the whole country. And we had 2 main waves with the peaks. The first peak was during the 20th week of 2020 and during the second week on 2021. And from the beginning of March, we are registering the 3rd wave, the 3rd peak, so we see the upward trend. Currently, the morbidity has stabilized for us, and currently we have registered 346,000 of infected cases. Over the whole period of monitoring, we identified some cases of a SARS-CoV-2 spread. And we had the chains of infection transmission with a couple of generations. And here you can see a couple of clusters of the infected. The first case was registered among the patient, or with the patient, who first was in Europe, and then we also see some infected cases coming from work, from their home, from their families, and a couple of cases were also registered after the contacts in the medical organizations. Starting from the very first case and up until now, our professionals in the field of epidemiology and sanitary measures track contacts and organize all the measures necessary in those nidi of infection. And on the one hand, this work allowed us to identify and track the chains of infectious cases, and it also allowed us to avoid the extreme numbers of the infected cases. And the majority of the infected cases were registered in Minsk and Minsk Oblast. And on the one hand, it is connected to the number of people living there. So the population of Minsk accounts for 37% of the whole country. And another aspect here is that this is a megacity and it has a lot of neighboring territories. As to the structure of the infected people, more than 90% of cases were registered among adults. And more than 65% were people of able-bodied age from 18 to 59%, and 29 cases were registered among people 60 years old plus. And so the majority of cases among children are registered among adolescents from 7 to 14 years. And so in the Republic of Belarus, to assess this epidemiological situation from different angles and to make informed management decisions, we monitor severe respiratory infections, pneumonias. Currently, as to the severe respiratory infections, this is not an epidemic for us. But in 2020 and during some weeks of 2021, we've seen some changes in the structure of the infected cases, because in the past, mostly children suffered from that. But in 2020, we saw that there were some changes coming. In the majority of weeks, registered some infected cases among adults. As to pneumonia, more than 90% of pneumonias are coming from the viruses, and more than 95% of pneumonias are connected and caused by SARS-CoV-2. Alongside with this, since 2020, we implemented an assessment of the virus transmission of the COVID-19 among our population. We have a system of surveillance. It has been in operation for quite a long time, and we do the surveillance in 18 regions of our republic. Here you can see the results of our work on the epidemiological surveillance. And over the period that was monitored, we see that there is a combined circulation of SARS-CoV-2 and non-flu viruses. And currently, we do not identify any viruses of flu. And here you see the results on the lab testing, proceeding from clinical and epidemiological parameters. We also test who go abroad. We also test people that are working in state medical organizations as well as in the private ones. The Ministry of Health of our republic identified the measures and identified the laboratories that are allowed to proceed with this testing. Our Ministry of Health, taking into account the order by the Council of the Ministers and also to prevent the bringing in of the infection to our country, it identified the red zone countries that are quite risky ones. And we've developed the criteria, and we monitor the COVID situation in these countries on a weekly basis, as well as monitor the measures that are taken there. And we restructure the list of these red countries, red zone countries. We can add some countries, we can exclude some countries, as well as we can adjust the requirements that are set for those who come from these countries home. As to the legal framework, we also have done a lot when it comes to the prevention of COVID-19. Here you can see just a couple of documents within the regulatory framework. And here I would like to pay some special attention to WHO. Well, there was a set of documents and recommendations prepared on the work of our system of healthcare against the backdrop of COVID. We've drafted methodological materials, videos. They highlight the issues of PPE's use as well as the protective clothes use. And as to the methodological base, we drafted the recommendations on how the different production sites should function, those sites that conduct some economic activities. And so we provided for the functioning of these organizations, even when there were some COVID-infected cases registered. So we, for example, organized the summer activities, and it all allowed us to proceed with the regular schedule of the health centers that are functioning in the summer, and none of these units stopped their activities. And the latest recommendations that we developed for COVID-19 situation, it was for some animals, and we developed recommendations for those organizations who work with animals and some cattle. So, the government of our republic developed and approved the vaccination plan. It all starts with the professional risk groups and other risk groups, and it ends with the vaccination of the whole population. And we want to vaccinate 60% of our population. Currently, we are finalizing the first stage of the vaccination, and currently we involve more than 33% of our medical staff for the purpose of vaccination, and we've vaccinated more than 70 people that are in hospitals and more than 18% of pharmaceutical workers. Currently, we've vaccinated over 2% of our population in total, so we have an extensive work to do in the future. So by this, I'd like to thank you for your attention and to wish you luck and health with the fight against the COVID. Okay, thank you very much. Dear colleagues, I believe that we will pose our questions from where we are seated. We still do social distancing, or you can also write something on a paper and then pass this paper to us. Now, I'd like to give the floor to Tatiana Bilichenko, the head of the Lab of Clinical Epidemiology, Research Institute of Pulmonology. She'll be talking about major clinical and epidemiological features of COVID-19 in Moscow. Good afternoon, dear colleagues. I'm very happy to welcome you. I'd like to wish you to stay healthy, wish you some well-being against this current backdrop. And I would like to present you the data that we drafted on the main clinical and epidemiological characteristics of COVID-19 among the Moscow population. For this, I've used the data only the official data from the Federal Service for Surveillance on Consumer Rights Protection and Human Well-being, the Healthcare Department of Moscow. We also used international sources as well as the Russian methodological recommendations that were drafted in January and February and then reviewed on a regular basis by the Federal Service for Surveillance on Consumer Rights Protection and Human Well-being. And we also used some scientific sources and articles. And we also used some databases on the number of infected cases with COVID-19 in Moscow and Moscow region. So the novel coronavirus announced itself on the 11th of December 2019 in China. We will remember this date forever. And on the 31st December 2019, the WHO knew about 425 cases with a severe pneumonia. And during 30 days, this disease was identified across the whole territory of China. On the 11th of March 2020, during the briefing, the Director General of WHO stated that the disease became the pandemic since it spread across 99 countries. And on the 11th of March 2020, Russia officially registered 20 COVID-19 infected cases of some mild state. 15 cases were registered in Moscow, and 1 case was registered with a child. And all these cases were brought to Russia from abroad. After that, the virus was studied thoroughly. The features of this were identified, and the pathogenic mechanism of this virus was proceeding from the contact with the ACE2 or transmembrane glycoprotein CD147. And by this, the virus could penetrate the cell, then start to spread. And that's how the severe damage to all the organs that included or consisted of this receptor started. And ACE2 are present in the human's body, on the endothelial, epithelial cells, on the erythrocytes, in our intestine system, and in many organs of ours, such as the heart, the kidneys, our brain, etc. Also, it is present in the lymphocytes, in the vessels, endothelium, and macrophages. So all the organs where these receptors are located could be suffering, depending, of course, on the severity of the disease. So the dynamics of COVID-19 disease can be observed in here. You see that as of the 31st of May, Russia registered 405,000 people of the infected cases, and well, the majority of this accounted for Moscow. Then, talking about Russia as a whole, we saw the spread of COVID-19 among the population with a higher frequency as compared to the frequency in Moscow. Because in Moscow, we organized quite a high quality and strict system of epidemiological measures. This system allowed to rein in the spread of the infection. But still, Moscow accounted for the most cases of the infected cases up to August 2020. And from the 31st of May through the 31st of August 2020, we registered some kind of a stabilization in Moscow regarding COVID-19. There was a downward trend in Moscow. And at the same time, we saw the rise in the infected cases in the Russian regions. People were coming from their vacation, and for example, children and aged people were coming back from different regions of Russia to Moscow. And in September, once again, registered the rise in the number of infected cases, and it was quite a sharp rise. It spread across not only socially active groups of population, but it also spread across children and aged people. We saw that the number of the aged population, or the part of the aged population, has risen from 11% to 19%, and the morbidity among children accounted for 11%. So we see that in Moscow, less people died from COVID-19 as compared to the whole Russia. It is mainly connected to the timely and proper treatment. So this is not only about the timely diagnostics, but also about the delivery of the medication, the work of the emergencies, the work of the mobile clinics, and we continuously monitored patients through the remote centers. It was organized in parallel with the work of COVID-19 hospitals across the whole territory of Moscow. The primary hospitalization of COVID-19 infected people was done according to the data from the information system that surveilled the morbidity. We saw that 70% of patients were administered to the infectious units, and the patients mainly were placed to the pulmonology units, then to the therapeutic units, and 0.3% were hospitalized to the intensive care units. In addition to that, the patients were also taken to the gynecologist units, coloproctological units, to the physiatry units, and other different units of different clinics. And In the isolation, they were once again tested, the diagnosis was confirmed once again, and they received the treatment or medication, or they were reprofiled or transferred to another unit of infections hospital. Here you can see that among 13,000 of people hospitalized to hospitals from the 1st of April through 25th of June 2020, 25% of all the infected people were hospitalized. And the bad consequences took place for those people who were suffering from different chronic diseases. And in addition to this, if there were some chronic diseases registered and identified, we also saw that there was a link with the age. So the older the people were, the more chronic diseases they had. You can see it represented in the red color on this slide. And the more frequently these patients were observed with the very bad consequences of this disease. And we see that 10,700 people, those hospitalized, got over the virus, and more than 1,000 died from this virus. And as to the detailed research of the deceased people, of the lethal cases, during the 3rd day and 65th day, after the people were infected with SARS-2, 69 male and 54 female patients were examined. As to the 6th of June 2020, the frequency of such diseases as diabetes, the ischemic heart disease, the obesity, the lungs problem, lymphoma, leukemia, some cancer diseases, we see that the risk has risen. And so definitely, dear colleagues, all these diseases, like in other countries, because our colleagues in other countries conducted the same analysis, these diseases are the factors that result in a very bad situation within the COVID-19. And the dynamics of the death rate of COVID-19 in Moscow as well as in Russia shows us that there was some rise in the death rate as it was assessed against all the official cases of COVID-19 among the population. And we can see that there was an upward trend up to the 31st of August.
At the same time, in Russia, lethality arrived at the level 1.73%, and in Moscow, it even exceeded this number. But fortunately, at the beginning of September, on the 5th September, namely in 2020, the mayor of Moscow announced that Moscow starts the round of vaccination of the high-risk groups in terms of COVID-19. These are medical staff, persons related to servicing of people having coronavirus, and also people who are at the nursing homes for elderly people or for people with disabilities, by the use of a new vaccine that was ready at this time to be used broadly. Further on, step by step, there was an increase in vaccination scope. And as you can see, at the end of November 2020, we arrived at a decrease of not only morbidity of population in Moscow, but also decrease in morbidity along Russia, and decrease of the lethality, so lethal outcomes that was related and conditioned by vaccination, by thorough work of sanitary epidemiological agencies, and in time drafting of clinical recommendation, proper training of doctors, of medical staff, huge events of mass raising awareness in population in all aspects, with pain-free covering of all issues that were faced by the population, which resulted in the betterment of sanitary epidemiological regime, better treatment of our patient, and rendering better healthcare services in clinical departments that were working with this patient. Unfortunately, distinguished colleagues, when we are arriving at better results, we are losing our vigilance. At the end of the March, you see that this curve is rising, not only in Moscow, although the rise is insignificant. Lethality was up to 154, but also in whole Russia, because we see the new times when the people are gathered, there is not so cold on the street, there is an increased social activity, and this is also playing its own role on these indexes. At the end of my presentation, I want to tell the things that you already know, colleagues, that infectious disease, COVID-19, is affecting whole population, all ages, but the unfavorable outcomes are faced by the people of the elderly age with chronic diseases. The execution of anti-epidemic measures should be obligatory for all people, whether you had your own flu shot or not, whether you had a case in your history of coronavirus, and so on, because we need to finalize the epidemic process. We need to regularly review and better up the methodology recommendation and introduce the achievements that we have for the last year in coping with this infection. It increases the quality of medical help and control of the disease. And vaccination, by the way, the broader the vaccination is, the broader layers of the community will be facing vaccination. Unfortunately, we have the active vaccine against SARS-CoV-2 virus. It will result in the decrease of lethality and morbidity rate, not only in populations in huge manufacturing cities with a high rate of contacts, social contacts, but also in villages. According to the data of the Department of Healthcare in Moscow that are officially published on the website of the department on the 31st March 2020, it was stated that according the 2021, I mean, according to the results of the tests in Moscow, antibodies to SARS-CoV-2 were evidenced by 44% of Moscow citizens. Therefore, colleagues, I want to remind you that with a person who can be diseased by coronavirus infection, we can meet this person every day in Moscow, because there are more than half of them, and clinical measures for us is the way for us to survive for the future. Distinguished colleagues, now you see all the information agenda. Get your vaccine and choose your health. And I want you to choose health and to wish you good luck. Distinguished colleagues, thank you very much for your kind attention. Tatiana Nikolaevna, thank you. So, Mikhail Andreevich Godkov will provide us with the report on the issues of organization of a work of a high-profile screening laboratory under COVID-19. I beg your pardon because I'm not fully naming the persons, but this is one of the leading specialists, and they are representing different scopes. Distinguished colleagues, greetings. I am representing the service that is working on the basis of diagnostics of coronavirus infection, and I want to thank the chair and the organizers for introduction and for invitation of our service today, because we want to share our experience here and tell about some interesting experiences. Just let us have some fun today for you to feel what was laboratory service making. So I am representing the Sklifosovsky Institute, the ambulance support, and our laboratory was among three biggest laboratories in Russia that have seen the laboratory, the major laboratory loads. And as the chair told, the laboratory executed more than 2 million researches for SARS-CoV-2, COVID-19. Our laboratory has 1.5 million of tests, but it's also a significant amount of research. So yes, I could manage this. So what did we face? So for a long time I work with laboratories in the system of the healthcare, and I am also the veteran here. And what we have seen, there are no rooms for laboratories. We needed specialized rooms, many of them, and in a rapid way. There was not so much gadgets. Even in the whole world, there was a lack in equipment. It's a fantastic thing, really. All of the gadgets were manufactured by pieces, and they were sold out by the manufacturers. All the systems of healthcare around the world were pursuing certain gadgets, and there were real competition on who will be the first one to buy the gadgets. Okay, gadgets hardware is 50%, but what about reagents? And here I want to thank the Institute of Epidemiology in Russia and to all test systems developers, because for me, as I have great experience here, this was the fantastic situation, because in a matter of days there was a new diagnostics. Yes, of course, there was a high percentage of non-specific reactions, but they were working still, and in a matter of no time we managed to make a diagnostics real. And this is the humanitarian experiment of the planet, because we are now facing a revolution in medicine, because this is the way of solidarity and of the overall world reaction on the epidemics. Today we were listening to our colleagues from Belarus Republic, and we need to say that we have pretty similar dynamics and pretty similar actions. For the first time we are coordinated so rapidly, and at the same time the coordination was not done on the level of state agencies, but on the level of scientists per se, of our level. And the third moment, there were no staff. Nobody knew how to work with these new methods. No doctors were trained to this. And physically, we had no such quantity of people. But the main idea is, Alexandr Vasilyevich was telling about this, we've lost the history of fighting against huge epidemics. There was a negative theory distributed, like the epidemics are not the case of today, that infectious diseases are something out of the range, and the world was not prepared to the epidemics, and epidemics went to us, and I am afraid that this is not the last epidemics, and there were many no's of such kind, and this is a complex set of problems. It is enlisted here. This is not a full complex, but it was faced by the laboratory services of the whole world, and we did not know how and what to diagnose, who needs to be diagnosed in the first line. There were no to the spectrum. We did not know. So, ideology. Very rapidly, the government of Moscow, in a matter of days, defined that you don't have to run diagnostics in all laboratories. You have to create a huge laboratory to provide for mass screenings. And independently, and this, by the way, was also revolutionary, independently from the means of whether it was private or the state, we used the private laboratories. I was at on the key meeting at Rakova, vice mayor of Moscow, and she told us, "Tell us, what do you need? We will buy everything." We told, we will need gadgets. They told, "We will bring you the gadgets," and they brought the gadgets, although the price was high. So we needed to provide for payments for the staff. Yes, they told that for this group of laboratories they will pay everything, and Moscow paid for everything, and we needed to create laboratories of different tiers. We could not create the same laboratories. Therefore, we created the ideology of multiple level laboratories in Moscow. At the same time, the load for these laboratories should be equal to the level of this laboratory. They could not define, or they could not run this the same amount of tests. On the first step, we did not know who needs to be checked. We defined that there are indications. We don't need to create panics like everybody let's go and get your tests. We need to make this definition. We needed to create the flows of patients to understand what are the flows of contingents of risk groups and load on laboratories. For example, in Moscow, we created a staff, and the staff was led not by the Department of Healthcare, but by us. I know in details a person who every evening sat there and defined what will be the load for every laboratory on each day, on every laboratory, and we knew what are the laboratories that we will work with which agencies. And this was a titanic amount of work. We needed to contact polyclinics, take the materials, invite the representatives, then provide for the gathering of all the probes to us, and we had the new deliveries at 10 o'clock in the evening, and we were working in night shifts because Rakova, deputy head, was telling us that in 24 hours we have to get the results, not later. So the spectrum of the scope of research, we understand this. On the first level, the RNA test, and very important is also the test for antibodies. It is also very important work also in terms of epidemiology. And so what should be these laboratories? Nobody knew about what the laboratories should be. I will tell you about this a bit later. So PCR tests. I am the head of a huge department at Sklifosovskoy Institute. This is an inter-regional laboratory, a very huge laboratory. We ran PCR tests before COVID-19 from 20 to 50 research. We worked 5 days a week, and we had only 2 specialists who were working with this method. And Rakova told us that in 2 weeks we needed to define 2,500 per 24 hours. We needed to work 24/7, and we've made it. We needed to create the independent branches and departments on the basis of the existing collectives or create new ones, and we've managed to solve this task. What about the scope of research? As I told you, our laboratory made from 20 to 50 researches. By the way, initially, the PCR is not a screening. It was not a screening. It was not used as a mass research, but the whole world was forced to put it into the rail of mass production. And a huge amount was the testing of 300 probes. I met Chinese colleagues, and one of renowned specialists told me, you know, we are making 300 probes, and at the moment we've told that we are making 5,000 per 24 hours. And he told me, impossible. And then I showed how our laboratory works, and we've achieved the result of 10,000 tests per 24 hours. So from 20 in 24 hours, 20 probes, to 10,000. What is the maximum that is possible? Okay, I know there are laboratories, I will not provide for PR of the colleagues, but these laboratories are providing for 20,000 per 24 hours. Of course, this is another organization of manufacturing of laboratory tests. These are different technologies. But at the same time, the loads cannot be distributed equally for all laboratories, because again, these laboratories is laboratory of Institute of Epidemiology, our laboratory. There should be not dozens of them, but they should be reserve laboratories. They need to persist and work on. I will tell you about this later. We understand that immune chemiluminescent analysis is something else, but still we have the gadgets and hardware, and we are able to make several thousands of research. Now we are making 5,000 of research, and we may make up till 30,000 of such kind of research. What about the venues? This is also very interesting. When we arrived at the question that we need 2,500 tests per day, we told that we have the amenities, we have the venues, and we need to rework them. Okay, they told us from the government of Moscow, high-class specialists will restore everything, but you will work. Okay, we worked. We were covering the gadgets, and we were covered by polyethylene, and the other guys, they were putting ventilation, cabling, and so on. So there are also videos of this, and this was the work on the basis of 24 hours a day, 7 days a week. We, together with the builders. And, you know, together with you, together with all of us, we were making something heroic, because this was the epoch of heroes. We were working together, and we needed to support the flows. The materials should be distributed within one flow, and we described to the builders and construction workers as how we see the material should go into the laboratory from the moment of entering the laboratory until the deactivation of the material. Of course, there were no projects, as you understand. Nobody was stating this. Everybody was working 24/7. And also reagents, reactive materials. These flows were outlined on the papers A4, for example, how the information will be distributed, where we will take off our coat, and when we will take the materials from patients, because we were also admitting patients. And correspondently to this, we were creating the logistic chains. We were making an outline with this, not 2 or 3 people. We were in consultancies with our colleagues. It can be doctor, it can be assistant or administrator. It did not play a role. The very important was the timing of the steps, because one step you can make it in a very rapid way, but it can result in problems on the next step, and we needed to synchronize work on every steps. And we made this spaghetti analysis, the movement of staff along the laboratory, and of course a very important aspect was the questionnaire of the workers who are working here, and we were asking whether it will fit or not, and when we told that it won't fit, some solution won't fit, it was rebuilt, reconstructed on the next day. Specialized rooms. We need specialized rooms for productive minimum. We created for a comfort amenities, additional light, air conditioning, and so on. On the day 10 or 15, there were workers approaching me, and they told me, it is okay, but what to eat? And we've asked restaurants to support, and the restaurants were delivering food 24/7. And you know, then I went to the department, and they told me we are not able to provide for this. And even with the hot meals 3 times a day, the operators of the laboratory are getting this, because you know the people need to work in the comfort. Heroic work can be a day, 2 days, a week, but not a year. And of course, complex use of technological amenities, technological rooms. These are rooms for cold storage, for storage, and so on. Hardware. Of course, when we worked with hardware, we needed to work with the automatized and manual methods, and we understood that they are giving us the equipment, but we don't have any knowledge on how to work with the equipment, and we needed also to understand how to use the manual methods. And along with this, we understood that the test systems will be changed. We will get different test systems, and we needed to be adapted to these changes in particular. Therefore, manual methods were also foreseen in our scope of work, and correspondingly, the load was defined according to the value that was prescribed for the laboratory. What about the staff? As I told you, at the initial stages of pandemic, there were dozens of people. But then we had a training of 250 people, about 250, and 150 are working right now. And we were collecting the staff. We did not know what are those people, and those people did not know what they will do. We knew that they have diploma and certificate. The majority of them were not aware of how PCR works. They needed to be trained, and in 24 hours they had to start the work. And this was a surprise for us, because they've managed to do this. There are many different people in the laboratory. I did not know who they are, but I had to leave them for the night shift. I could not stay there every night. And we create mixed brigades, for example. The one who worked for 4 to 5 days he or she was the elder one, he was just the leader of the shift. This is like on a war, you know, like the newcomers. After 1 week, if you survive, you are the old guy. And by the way, the people had different goals. Somebody was searching for money, somebody was an altruist, somebody wanted to work for the fame, and we needed to choose this. This is a very important step, and we need to work on this, and I hope that the leaders of some collectives, some staff groups will listen to me, because the situations will be the same. We need to be prepared. We need to work with psychology of collective, of the staff under this extreme situation. Majority of people who went to us, they understood that they are here for a time. So what can you ask from the person who works this part-time job? And this was the job for a night, and many people did not want to work these night shifts. They wanted to work in the other shifts. And this was a huge share of liability for us, because we were working with diagnosis.
How did we address all that? From the very beginning, when we've got a new person, we wanted to provide for the understanding by this person what is his or her goal and what is his or her functions. The newcomers should understand what the team is doing as a whole and what they should do. Well, of course, we had some changes in our personnel, and we had to lay off only 2 people, and we couldn't allow for more. So all these decisions are quite important. Why? Because proceeding from the data from the world literature, and I also believe in that we will face some more pandemics, unfortunately, in the future. And what infections will we face and what we'll have to respond to, unfortunately, we do not know anything about it. So, on the one hand, we have to preserve these fundamental labs that will allow us to identify some pathogens and to conduct some screening. And on the other hand, we also have to preserve all the technologies and methods how to fight against the massive pandemics. And everything that has been mentioned today should be taken into account. Okay, thank you. Thank you very much. And our next report will be by Elena Meskina. She'll be talking about clinical and epidemiological analysis of disease in children of the Moscow Oblast. Distinguished Alexander Vasilyevich, distinguished colleagues, good afternoon. I would like to present you the data on the Moscow region, Moscow Oblast, in other words. So, this is the second largest region after Moscow. It is close to Moscow. And in these 2 regions, in Moscow and the Moscow Oblast, the pandemic in Russia started. We have over almost 2 million people, and the children account for about 20%. In total, we registered more than 230,000 cases, and 18,000 were identified within children, so it is less than 8%. So we do see that children suffer less from COVID. As to the dynamics of the morbidity, it showed some exponential growth also among people or among children. It happened in April, then the morbidity rate stabilized. This trend is quite a characteristic and natural one for Moscow and the Moscow Oblast. So, among 100,000 children in Moscow Oblast, about 15,000 were infected. And here you can see the geographical picture of the virus spread. And you see that those regions that were closer to Moscow suffered more, and those who are further from Moscow suffered less. But this is not the only aspect that we should take into account here. So, if we take a look at the morbidity level, then we can draw a conclusion very clearly that the morbidity rate was higher in those or on those territories with the more dense population. But we also see that there are different factors that can affect the morbidity rate. Here you can see the proportion by sex. Well, on the one hand, it seemed that adolescents suffered more from COVID, but if we take a look at different groups of age or by age, well, the groups were affected quite in the same manner. We see that the children under 1 year old suffered more, but they got over it in quite a mild form. So indeed, children under 1 year old got infected more frequently, but they do not suffer more than others. So in total, starting from April through the March 2021, 40 cases are asymptomatic, and during the start of the pandemic, it accounted for 60%. As to the pneumonia among children, well, not a lot of cases. In the beginning, it accounted for 20%, and very, very rarely we identified some severe forms of pneumonia. So indeed, we had just about 60 cases. So judging by proportion, this is not so much. And when it comes to the sources of the pediatric morbidity, we see different, indeed, sources of foci. 75% of children got infected in the foci. And when we talk about the family foci and the sources and the just public foci, then we see that people or children mostly got infected within their families. It accounted for 75%. So on the left side of this, you can see the morbidity rate by months, and in the right, you can see very clearly that when the morbidity dropped during the summer, we saw at the same time that the proportion of children under 1 year old grew. And we can also see that in the beginning of autumn, adolescents suffered more, so their proportion rose. Well, this is quite understandable because they went to school and some other educational facilities, and no measures were introduced during those times. If we take a look at the A graph, then we can see the monthly cases. And the red line is the share of children in the total number of all people infected. And we see that the number of cases is decreasing and the share of children is rising in parallel with this. I believe that this is mostly connected to the fact that children are a focus of our attention, and we continue to monitor them during all the stages of the pandemic. And what I would like to draw your attention to is that when during the summer the morbidity rate fell, especially in August and September, it is visible. I believe that this situation requires some additional analysis. So we didn't only experience the change in the age structure, but we also experienced some change in the forms, I mean the mild forms and severe forms. I believe that it should be analyzed. And if we take a look at the share of children hospitalized among the total number of children infected, we see that when there is an upward trend among children, then the number of hospitalizations when there is downward trend among the infected cases, in parallel, it is followed by an upward trend or in the hospitalization of children. So what I would also like to mention here is that if we take a look at the age, then I believe that the morbidity among babies, we can see it here. This is the marker of the growth in infected cases. So when we experience some growth of infections among babies, then it will probably result in the rise among the whole population. And so this monitoring, the surveillance and epidemiological monitoring showed that in general children suffered less and got infected less as compared to adults. And if we take a look at these graphs, then we can see that, well, those who had some contacts with some people infected, they got some immunity. So, dear colleagues, I would like to support all the calls of our colleagues that we should get vaccinated. So the analysis shows that the pandemic development is a complex one. It proceeds from the number of a set of different factors, and these factors change in parallel with the epidemiological process, and it also changes by seasons. And of course, the approach of patients towards the pandemic can affect it quite a lot. And so, of course, it all influences the indicators that we register. So indeed, children get infected less frequently than adults. Then we see the very even age structure. We didn't register any differences per age when it comes to the morbidity rate and death rate. While children of all the ages get over the infection in the same manner. Also, we didn't register any dependency on the age when it comes to the severity of the disease. We didn't see any spike or any rise in the pandemic among children as of today. And the share of pneumonias has always been the same. If we track it by day, by week, by month, doesn't matter. And so, as I've said, children mostly get infected in their family, and children get infected at school less frequently, despite the very close contacts, but still apparently the contacts at school are not so close as in their families. Okay, thank you very much. Dear colleagues, we will consume a bit of your time because we have another report to present to you. And I give the floor to Arsene Arakelian, the director of Institute of Molecular Biology of National Academy of Science, Republic of Armenia. And he'll be talking about the molecular genetic analysis of SARS-CoV-2 in clinical samples by methods of nanopore sequencing. Okay, thank you very much. I still will try to be brief here. First, I'd like to thank you for the opportunity to be presenting. And now I'd like to present you the work that we conducted jointly with the National Center on the Prevention and Control of the Diseases. Our institute works within the system of the Academy of Sciences, and from the very beginning of the pandemic in Armenia, which is March 2020, we started to cooperate with the Ministry of Health of our republic, and in particular with our CDC. So, the data on Armenia. The first case was registered on the 1st of March 2020, and as of the 15th of April 2021, we have 206,000 confirmed cases. Currently, about 16,000 people are treated right now. The number of deaths is almost 4,000. So, when it comes to this pandemic and the fight against this pandemic, I can think that this is a triumph of the sequencing methods. Because from the very beginning of all this, sequencing played quite a role, and they allowed us to identify very fast the virus itself, to sequence it fully when it comes to its genome, and it laid the foundation for Pcr tests. It also allowed us to analyze the evolution of the virus as well as the circulating genetic lines. We studied the adaptation, and it all helped us to develop the vaccines. So all the areas that are now quite actively used, or all the methods that are currently used in the fight against the coronavirus, it all proceeded from the sequencing methods. If briefly we will take a look at the technologies, well, we have the sphere of application for each of the technologies, and we have, of course, the sets and protocols in connection to the coronavirus. So we see that there is the Singer sequencing. This is the gold standard, but it is highly precise. It has some lengthy reading, but it has a low throughput. And the Sanger sequencing also allows us to conduct with the S gene screening and the screening of those mutations that are connected to the contagiousness of the virus. So the golden standard during the pandemic was the sequencing of the next generation NGS sequencing. It is very precise. The cost is quite normal, but the readings are quite short ones. And also, we didn't have enough equipment for this. For example, we lacked some equipment for PCR, some agents, etc. And we also lacked this equipment for this type of sequencing. And also, the protocol is not an easy one, and one has to have quite an experience to do all this. And one should spend a lot of time to get adjusted to the protocol and the laboratory. And nanopore sequencing methods are also moving forward. First, it could resemble some just toy or simulator that you can show to school students or university students, but we turn them into a tool also to study the virus, especially during the pandemic. And when it comes to nanopore sequencing, it has an advantage of long readings. So you can have some very large part of the genome with a good coverage. As to the library drafting preparation for nanopore sequencing, this process is quite simpler as compared to the sequencing on an Illumina platform, for example. But where there are advantages, there are also disadvantages. The nanopore sequencing is not as precise as the previous methods that I mentioned. But we can provide for some full coverage or good coverage. And if we combine, for example, nanopore sequencing and sequencing for Illumina, then we can get the coverage of genome of 99.9%. So it is quite a good result. For our study, we used the protocol that had been already validated by a lot of scientific groups across the whole world. Well, I will not stop and pause and tell you about workflow a lot. So we got 36 clinical samples that we got on the 22nd and 29th January of this year and the 18th of March 2021. So it was the randomized study. But we had quite high CT on PCR results. So we prepared our library, proceeding from the method that had been described quite a long time ago. We used Arctic panel. It provides the primaries for NGS as well as nanopore sequencing. So we used MinION equipment. It's quite a small piece of equipment. It just looks like a USB stick. So we done it from 6 to 8 hours, and the average coverage of the genome was the 350 X per nucleotide, and our specialist in the field of bioinformatics developed a pipeline for the preparatory analysis of data. So actually, First, we do the pre-sequencing, then sequencing, and then we analyze the variants that were identified in our clinical samples. And we identified the viral lines and analyzed whether the mutations that we found can influence on the efficiency of the connection of primers between PCR and sequencing. Especially, we were interested in those PCR tests that are currently used in Armenia. As of January 2021, January 21st and January 29th, 90% of all our samples identified the lineage 11163, and according to Pcr lineage, this is called the Russian lineage, because this lineage was found in Russia mostly. In all the lineage, we saw some standard mutations. We identified it in May, and in this line, we can see some mutations that are quite characteristic of the UK strain of 117. And in March, the situation has changed a lot. Out of 12 samples that were sequenced, 10 identified the mutation of 117. And we could compare it, proceeding from the Pcr system, to the UK variant. So we see that the situation with variants in Armenia has changed a lot. And if we compare the number of mutations across these lineages, then we can say that when it comes to 11163 lineage, then the average number of mutations per genome is much lower as compared to the UK variant of the coronavirus. We conducted the phylogenetic analysis of these lineages, proceeding from the GSIDE and other database. Our genomes are characterized all within the one branch. They were quite similar to the Europe. Taking into account the airway traffic, we can probably suggest that the transmission of this virus to Armenia was done through Europe to Russia to Armenia, or just from Russia to Armenia, because this kind of a lineage is commonly identified in Russia. On the other hand, the phylogenetic analysis of the sequencing of 117, the UK strain or variant, we can see that our genomes are clustered in different branches of this tree, phylogenetic tree. So some of them are clustered in Europe, some of them with the same sequence are found in Asia and Africa. And we can see that there are different trajectories of transmission of this lineage in Armenia. The most important question that interests almost everybody who work in a lab is whether the mutations can influence the PCR accuracy as well as sequencing. So we also conducted an analysis to identify whether our mutations are located in the regions on primers. And we see that a lot of mutations are localized on primers that are recommended by Arctic Protocol, and we observed it also during the sequencing. We've got some fragments with quite a low coverage of the genome, and we use PCR sets that are proceeding from the CDC primers from China and the American CDC as well. And so we studied whether the mutations can influence these regions of primers. So we've identified mutations in 12 samples for N gene primer, both forward and reverse ones. All the mutations that we found were localized within the 5 ends of this, and so it shouldn't influence the accuracy of PCR. And the samples that we identified and selected were positive along 2 channels, so for N gene and for the other gene. And our results confirmed our suggestions. And a lot of mutations we identified also for primers that were designed for E gene. And some of these mutations were quite close to the site of this primer, and it can influence the results of the analysis of PCR. And well, most sets that we use in Armenia, they target the N gene or ORF1 gene. So what conclusions can we draw? To sum up, well, in general, this strain, the UK strain, got to Armenia in February-March 2021. I'm talking about B117. So those mutations that we found in the genomes of our clinical samples do not influence the accuracy of PCR tests, but we still need to continue these studies. So we have to extend our selection of samples. And the regular and periodic genome sequencing of the SARS-CoV-2 virus strains is necessary for the monitoring of the epidemiological situation, and the nanopore sequencing is the reliable and accessible alternative for molecular and epidemiological study if there is no access to NGS platform or the access is quite difficult to obtain. Hereby, I'd like to thank my colleagues from different scientific institutions that helped us to conduct our work, and also hereby I'd like to thank you for your attention. Okay, thank you very much. Dear colleagues, do you have any questions to our presenters? If you don't have any questions, then I'd like to thank everybody, each and every speaker for their presentations. And I would like to invite everybody to come to the National Congress, the 13th Congress on the infectious diseases, named after Mr. Pokrovsky, on the starting on the 24th of May. It will be conducted in the Radisson Slavianska near the Kievsky railway station. So we still have, of course, some limitations of a 50% filling of the room, but still we hope to meet you over there. Thank you.